Everybody. The topic for my presentation is clinical trials in diabetic macular edema and their practical relevance today. And I would like to acknowledge Dr. Rajiv Raman for providing some of the data. There is no financial disclosure. In management of diabetic macular edema, laser photocoagulation has been a gold standard. Then in 1970s, we had various trials in ophthalmology on the role of diabetic retinopathy. In that early treatment diabetic retinopathy study showed a clear-cut role of laser photocoagulation in managing diabetic macular edema, which it showed that laser therapy reduced the relative risk of losing 15 letters of visual acuity by 50% comparing with different treatment. So that time we didn't have any treatment where we can think of improving the vision in such cases. And these unmet medical need led to invention of other therapies which could restore vision in patients with diabetic macular edema who had visual impairment. So now the role has shifted from laser to pharmacotherapy in management of diabetic macular edema, and various clinical trials have been conducted. So I'll be discussing some important clinical trials in diabetic macular edema. Protocol A was a pilot study of laser photocoagulation in diabetic macular edema, which they compared a conventional laser, what we do, focal laser as per ETDRS protocol, with a mild macular grid laser, where in mild macular grid laser, there were small mild burns were put throughout macula in areas without macular edema, and no direct treatment of macroembolism was done. It showed that mild macular grid laser is less effective than what we do conventional laser, but visual acuity remained similar in both the groups. Another protocol which showed it was a randomized trial comparing intravitreal steroid triamcinolone acetonide with laser photocoagulation in management of diabetic macular edema. It was in 2001 and 2002 when first benefit of steroids, intravitreal steroids were reported in literature. There was a short-term visual improvement, and there was a rapid decrease in retinal thickening on cases of diffuse macular edema. So this trial was conducted to see the safety and efficacy of 1 milligram and 4 milligrams of preservative-free IVTA with focal and grid laser. And there was a clear-cut improvement in initial 4 to 12 months with steroids, but if you see over a period of 2 years, the laser has a major benefit role in improvement of visual acuity, and while the steroid, again, it dropped. So the take-home message was focal and grid laser is most effective modality of treatment for DME, and if you compare with steroids, then you have to think of other drugs also, because the effect doesn't remain permanent. In protocol D, there was evaluation of vitrectomy for diabetic macular edema, and cases were chosen who had apparent vitreomacular traction with loss of vision, and OCT with a center subfield thickness of more than 300 micron cases were included, and additional some procedure ERM peeling, ILM peeling was also done in such cases. If you see anatomically, 2/3 of eyes had 50% reduction in central subfoveal thickness. But if you see functionally, visual acuity improved in 37% of the cases at 6 months, but there were another 23% patients who had a drop in vision of more than 10 lines at 6 months. So visual acuity results are very not consistent in all the cases who are undergoing vitrectomy, which has to be considered in mind. In protocol E, these cases of diabetic macular edema, early diabetic macular edema, the role of peribulbous steroids are evaluated, because intravitreal steroids with 20/40 vision is not a good idea, and cases were randomized for posterior subtenon plus laser, focal laser, anti-subtenon plus laser, or only the posterior subtenon tricot injection. Results showed there was a trend towards a reduction in retinal thickening over 34 weeks in all 5 groups, but there was no consistent pattern across these 4 groups. And this study did not find evidence of clinically meaningful benefit of peribulbar steroids as a treatment for mild DME in such cases. It means you don't have to give peribulbar steroid in such cases, it is not going to benefit. Another study, it was a study regarding the development of DME following scatter laser photocoagulation. What we do routinely is 3 to 4 sittings of laser photocoagulation in a diabetic patient, considering that it may precipitate macular edema. In this study, patients received around 1400 to 600 burns in a single sitting compared with the other settings of 4 settings. And this group did not have any major macular edema even if you do a single sitting of laser photocoagulation, and with no resultant loss of vision. In subclinical diabetic macular edema study, subclinical diabetic macular edema is defined as no edema involving the center of fovea as determined by microscopy, but with the central point thickness on OCT is at least 225 micron, but less than 299 micron, which we take as a clinically significant macular edema involving the central subfield. So to determine the rate of progression of eyes with subclinical diabetic macular edema to clinically apparent diabetic macular edema over a 2-year period was evaluated. It showed that 27% of patients, they progressed to clinically significant diabetic macular edema in 1 year and 38% by another 2 years. So the take-home message is 1/4 to 1/2 of eyes with subclinical DME will progress to more definite thickening over a period of time within 2 years. Coming on to the role of bevacizumab in diabetic macular edema, the role was compared with focal laser and 1.25 milligram dose and 2.5 milligram dose of bevacizumab in reduction of central retinal thickness over 3 weeks period. Dose 2.5 milligram produced a greater short-term reduction of OCT as measured by OCT if you compare with 1.25 milligram duration. But if you see the reduction in retinal thickness associated with bevacizumab at 3 weeks apparent to plateau or decrease in most of the eyes between 3 to 6 weeks. So probably a 4 weeks duration will be a good time to give another injection. Even if you have to repeat the injection after second injection, 4 weeks is an ideal time, because we say that bevacizumab has a long period to be stay in the eyes, but 4 weeks is a good time. And also combining photocoagulation with bevacizumab resulted in no short-term benefit or adverse outcomes. Coming on to the laser versus ranibizumab and steroid study for DME. The study compared the sham plus laser, ranibizumab plus prompt laser, ranibizumab by deafening laser, and transluminate plus prompt laser. And intravitreal ranibizumab with prompt or deferred laser had a better effect in terms of visual acuity. More than 50% of patients had a substantial improvement, more than 10 letters, while 30% gained more than 15 letters. In pseudophakic eyes, steroids, they also play a good role if you compare with the phakic patients, and the results were equally effective if you see the pseudophakic eyes where the ranibizumab was given in phakic eyes. And the course of response to focal photocoagulation to DME was shown in protocol K. Study was done to determine the effect of deferral after retreatment in eyes that were improving with initial focal laser, because we tend to do laser after 6 weeks if the patient is not showing response. In this, they deferred the laser for another 16 weeks. 23% of the eyes showed improvement in macular thickness over 16 weeks without fully resolving. Thus, continuing improvement past 16 weeks is seen in 10% of the eyes in all study. And eyes with greater macular thickness had a higher frequency of continued improvement after 16 weeks. So the message is, the results do not imply that visual acuity outcome will be better if retreatment is deferred at 16 weeks. And further trials are required to see whether the additional improvement might have occurred if the treatment was not withheld at 16 weeks. Another trial, result trial, it had ranibizumab treatment every month. Treatment was given 0.3 milligram dose compared with sham treatment and compared with 0.5 milligram of dosage. And photocoagulation was done even 3 injections were not reducing the retinal thickness. Then the photocoagulation rescue treatment was offered. If you see the mean vision change from baseline had a gap of 9.6 letters over 2 years of time, over 1 year period. If you compare with the sham treatment, and the mean central retinal thickness, it changed remarkably and it remained reduced till 12 months of follow-up. So in result study at 12 months, ranibizumab treated patients gained 10.3 letters in visual acuity with a mean of 10 injections versus a loss of 1.44 letters in sham group. Dose doubling was more frequent in the sham group, and a higher proportion of patients in sham group received rescue laser therapy. And there was no, the incidence of non-ocular side effects was not significant, and there was no increased rate of CVS or cerebrovascular events. The RESTORE study was a 12-month randomized phase 3 study with 345 patients, in which ranibizumab monotherapy and ranibizumab combined with laser or laser monotherapy was evaluated. And injections were given at 1 month interval with minimum of 3 injections until the disease stability was achieved. And laser was administered in accordance with ETDS guidelines. The primary endpoint was the mean average change in vision acuity at 12 months. And it showed a superiority of ranibizumab either monotherapy or whether combined with laser or compared with laser monotherapy. And another study, BOLD study, which evaluated the role of intravitreal bevacizumab or laser therapy in management of diabetic macular edema. It showed a clear-cut evidence of more than 8 letters of gain in the study protocol with bevacizumab. Another study, READ-2, where the role of grid laser, ranibizumab alone, and ranibizumab with grid laser was evaluated, and only ranibizumab alone showed more than 3 lines of improvement in 22% of the patients at 12 months period. Interestingly, adding laser to ranibizumab resulted in fewer ranibizumab injections without a major disadvantage in visual outcome at 2 and 3 years. In Da Vinci study, the role of aflibercept was shown with the 0.5 milligram dosage every 4 weeks, 2 milligram every 4 weeks, and 2 milligram every 8 weeks, and 2 milligram as needed. At 24 weeks, the main change in vision acuity for aflibercept arms ranged from plus 8.5 to 11.4 letters, showing a clear-cut role. So, in concluding that the studies of DRCR, READ, RISE, and RESTORE studies, they have provided the evidence for pharmacotherapy in management of diabetic macular edema, and the role now is shifting from laser photocoagulation to pharmacotherapy. Thank you very much.
Thanks. Thank you.